So welcome, we're here today with Dr McLean from Orthopaedic SA, an upper limb orthopaedic surgeon. I'm going to talk about shoulder dislocations. Thanks for joining us, Dr McLean.
Thanks for having me.
Just to start off with, tell us about yourself and your practice.
Certainly. I practice primarily shoulder and upper limb surgery, and have done so here at the Royal Adelaide Hospital and at Orthopaedic SA privately. My practice is primarily based here in Adelaide. I also consult out at Central Districts and down at Flinders Private. I have a special interest in both research and shoulder arthroplasty and soft tissue arthroscopic or keyhole surgery.
Yeah, great. So we're here today to talk about shoulder dislocation. So can you tell us a bit about shoulder dislocation? What's the common direction that the shoulder dislocates, say in a sporting injury, and what are the symptoms that patients usually come in with?
Absolutely. It's pretty common actually. It's a seasonal injury, so we often find that footballers and high energy activities lead to injuries of that description. The most common one is an anterior dislocation of the ball and socket joint, or the glenohumeral joint. Yep. And what we often find is that patients put their arm out like this, so abduction of the shoulder, yep, and combine external rotation with a force directed from the back forwards, and the head actually pops out the front. They commonly complain of a pain and a sensation of the shoulder feeling like it's out of joint and inability to move that joint, and often that requires end location of the ball and socket joint in a emergency department.
Yeah, good. That was my next question. What's the initial treatment if someone does dislocate their shoulder? I suppose it could relocate itself, or it may not. So
certainly, it's pretty uncommon for a primary dislocation to relocate itself the first time. Yep. Certainly, patients who have recurring dislocations can sometimes relocate that shoulder themselves, either through some specific manoeuvre or because it's so unstable.
Right.
But if you find yourself facing a first-time dislocator, say on the football field, yep, it's often best to wait for the emergency department staff, such as the ambulance officers, to give them some sedation before attempting a reduction yourself.
Yeah.
Sometimes the first-time dislocators can have some soft tissue interposition, so it can be relatively difficult to end-locate them. You often find that there's a palpable lump at the front of the shoulder, and patients will often hold the side of their arm to stop it from moving, which commonly causes more pain than anything else.
Okay. And then is imaging, when you see these patients and they come to see you, is imaging important, and why, and what images do you take?
Certainly. The two most important things are firstly to confirm that the shoulder is dislocated and there's no associated fracture. Yep. So plain radiographs, so x-rays, can be very helpful in terms of both diagnosing and looking for associated issues. Yep. The most important view is what we call an axillary view, where we take a shot from within the axilla aiming upwards, and that often shows the position of the ball and socket in relation to one another. What you'll often find is the ball is sitting either in front of the socket or sitting behind the socket. 99 times out of 10 it's sitting in front, which is that anterior dislocation. So that's probably the first thing that I would do in the emergency situation. Once we've done the reduction, we do the same shot, so axillary shot, to make sure that the shoulder is end located before putting the patient in a sling. The sling is really for comfort initially. Okay. It doesn't really need to be used any further beyond that.
Okay, great. And like a lot of things that we see, there can be conservative management and there can be surgical management. How do you clinically make a decision about what's appropriate for that particular patient when they come to see you after a dislocation?
Certainly. Probably the most common prognostic factor is actually age and activity level. Okay. So what we find is that patients under the age of 30 have a much higher chance of redislocating. That's simply because of the activities that they're involved with, yep, and the position that they may put their arms in. People in their 40s and 50s don't tend to do, say, high risk activities or associated sports, yep, so they're at a much lower risk. The quoted literature suggests that there's a 90% chance of recurrence in patients less than the age of 30, whereas that drops to less than 10% above the age of 30. So there's a clear discrepancy between those two age groups. In those that are less than 30, physiotherapy aimed at strengthening the dynamic stabilisers, or the muscles around it, can be very effective in terms of holding and restabilising ball and socket to allow for healing to occur. However, there can be some mechanical damage that occurs to the ball and socket component, which despite adequate and timely physiotherapy may not be able to compensate for that mechanical damage that's been sustained. So in those patients that have the ongoing feeling of discomfort and often pain, I review those with an MRI scan, looking for labral lesions and bony Bankart lesions, which would lead me more towards fixing them.
Okay, great. And if you were to fix someone's shoulder with a surgical option in this case, how long would it be till they would potentially return to their sport? And then if it was conservative management and they didn't require surgery because there was no lesions and things going on, typically how long do they take to return to their sport? Let's just say football, because we typically see that here.
Football is a high impact activity, so often caution is best, and so there's a protective phase of the rehabilitation, and then there's a rehabilitation phase. The protective phase from a surgical point of view is that time at which it takes the labrum to heal back onto the bone effectively before we can move to the rehabilitation phase, and that's normally in the order of 6 to 8 weeks. So during that protective phase we try and maintain shoulder range of motion, so both passive and active assisted range of motion exercises are very effective and helpful in maintaining that. And then beyond that we can lift those restrictions and rehabilitate the patient in terms of the muscle bulk that's lost and sport specific exercises that they need for whichever sport they're into. And that process depends on a lot of factors, including individual patients, pre-morbid level of exercise and level of fitness. So someone who's, say, a high elite athlete, for example, will rehabilitate a lot quicker than someone who only plays weekend football. And that's normally in the order of about 3 months. So you're looking at an 8-week protective phase followed by 3-month rehabilitation before they're ready to go back to sports. And that's for the operative candidate. For the non-operative candidate, you're probably looking for at the same level in terms of the healing of the soft tissue, but probably a quicker rehabilitation phase in the order of 6 weeks as opposed to 3 months.
Okay, great. So when would you consider the patient safe to return to their, say, contact sport? And how do you make that decision? Yeah,
most certainly. So there are several factors that I take into consideration when considering this. There are surgical factors and patient factors. The surgical factors relate to the time from which the initial injury occurred to the time of operation and the quality of the tissue that we're able to repair at that time. So someone that's waited, say, 6 years for their operation is going to have very scarred tissue, as opposed to someone who's waited 6 days. So the quality of the repair in the latter group is going to be better, so they'll be able to be moved through those phases quicker. Also, the type of repair that I were to do, so whether or not that's arthroscopic, i.e. keyhole, or an open repair, especially in the chronic redislocating group, influences the healing time and the amount of scar tissue that we need to consider when moving them on to that next phase. Also, the type of repair that's performed, so that can range anywhere from a small part of the labrum, which is the socket part of the ball and socket, to the entire labrum, both on the front and the back. So if that needs to be protected, there's going to be a lot more scar tissue, and the rehabilitation once again is going to be very prolonged. Then there are patient factors, so someone that is returning to high impact activities such as Australian rules football or rugby will have higher demands than someone that's returning to a relatively low impact sport like badminton or tennis. So often sport specific exercises need to be taken into consideration, and targeting those muscle groups that those individuals use more so than others is a good way to work towards that.
Fantastic. I think we've learned a bit more about shoulder dislocation and hopefully how to manage it well and who to go and see. So if you've got any particular questions about that, Dr McLean can be contacted here in Adelaide at Orthopaedic SA. And again, I'd recommend that you do that. So thank you very much for your time today, and good luck.
Thank you.
Thank you.